Hi everyone, Dr. Chris Paris here, the DIO and Clinical Dean at Brookdale University Hospital in Brooklyn, New York. Why are we here today? We're here today to do our endocrine section for our Step 2 board review course. I'm also triple boarded in internal medicine, endocrinology, and clinical hypertension. And I'm here to take you on the wild ride of endocrine. Why? Because I know that endocrine is tied for the third most common system you will see in your exam. And I also know endocrine causes significant anxiety in the majority of medical students I've ever come across in my career. But that's okay, because I will be your lorazepam. By the time you're done with our endocrine section, not only will you rock Step 2, the endocrine questions on Step 2, you will likely want to become an endocrinologist just like me, okay? And you may even want to become an endocrinologist in our own institution, and you may want to come to Brookdale, and you may come into my office and say, hey, Dr. P, I want to be an endocrinologist just like you. And I do say endocrinologist for a reason. All right, so sit back, have some fun, and we'll learn some hormones. We'll start with some pituitary disorders. So what is a pituitary incidentalloma? It's an incidentally discovered nodule on the pituitary gland. That's what it is, meaning you're scanning the brain for something else, maybe a migraine, maybe a bleed, whatever the case may be, a headache, and oops, it's like a 4mm little lump on the pituitary gland. But what do you do about it? What do we do for asymptomatic pituitary bumps that you didn't even know were there? Well, first and foremost, what's important is size. Size matters. And under 1 centimeter, most pituitary nodules, and I will tell you, endocrine nodules overall, whether you're dealing with thyroid or adrenal, whatever the case may be, your two major concerns are size and function. And our major cutoff for size concerns is 1 centimeter. So under 1 centimeter is considered a microadenoma, above 1 is considered a macroadenoma. So that's size consideration. When it comes to functional consideration, prolactin's where the money is. Why is prolactin where the money is? Because it is the most productive pituitary nodular tumor. I don't like to use the word tumor because it scares people, but the fact is adenoma is a neoplasm, but it's a benign neoplasm. So if you do have a pituitary incidentalloma, right, you found something you weren't expecting to find, you check prolactin and it's perfectly clear, there's normal levels, no clinical problems, no clinical symptoms. What do? We follow yearly with imaging, with a yearly MRI. And MRI is the imaging test of choice for pituitary. Let me be clear about that, not CAT scan. Barring one exception, which we'll talk about later. MRI is the imaging test of choice. Now, what if the pituitary nodule is big? What if it's over 1 centimeter? Ooh, scary. It's so scary. Right, guess what? You still check a prolactin level. So size here doesn't matter. It's all about, you still have to check functionality. So prolactin still matters. The only difference will be if you're dealing with a legitimate prolactinoma, the prolactin levels will be higher. They should be higher compared to a microadenoma. And guess what? They still get a yearly MRI as well. Now, when you're dealing with larger pituitary adenomas, there's other considerations you have to worry about though. Because the bigger the pituitary adenoma, remember the pituitary is this tiny, weensy little peanut of a gland living in the cell turcica somewhere in here. So the bigger the adenoma is, it may push and press on the little itsy-weetsy pituitary, causing pressure necrosis. So at that point, you have to worry about other functionalities, such as who? Cortisol. Why? Because adrenal function is critical to life. What other functions are critical to life? Thyroid. Those are the two big ones. Now, other aspects of pituitary functionality include LH, FSH, the gonadal axis, growth hormone, right? IGF-1. These are not critical to life. So your first and foremost concerns when it comes to functionality is cortisol and thyroid axis. After that, then you can worry about the rest. Now, there is a term called empty sella syndrome. And I will tell you, more often than not, it's a misnomer because all it means is that the MRI does not see the pituitary on the cut. That's what it means. But it does not mean the pituitary is not there. It could be flat. And the MRI cut, right? MRI cuts, zoom. But on that one cut, it doesn't see it. Now, on a rare occasion, you may legitimately have a genetic disorder or genetic problem leading to lack of a genesis of a pituitary gland, but that usually presents in very young patients. In adults, the most common situation you're going to see is trauma. You're going to see previous history of radiation therapy, some aspect like that. And if it's chronic, it's not usually a problem. So like an incidentalloma, a bump on the thyroid, more commonly than not, you will find empty sella or ESS as what? Incidentally. You're not even going to know it's there because you're not going to have a clinical problem. And what's it most oftenly associated with? The real answer is Usually nothing. It's usually asymptomatic. So symptom-wise, it's not associated with much. When you're dealing with causes, that's where the money is. You always want to ask why. Why would the pituitary be so small or so atrophic that the MRI cannot see it? Such as what? Such as surgeries, such as overweight, such as previous radiation therapy. Maybe a childhood meningioma or a childhood brain tumor, whatever the case may be. 70% of them are, what does that mean? 70% of the time, what will empty cell present as? It will present as nothing, and it will be idiopathic. And why is it idiopathic? Because we're idiots and we don't know the pathology behind it. That's why it's idiopathic, right? And when you see empty cell syndrome, what is your answer always going to be? When you see it as a question, for the record, even in real life, I will tell you, I get a few consults every year for empty cell syndrome, but at the end of the day, what do you care about if you cannot find the pituitary? You have a patient in front of you, right? You're in your office. Hi, how's it going? My name is Mr. X. Why are you here? Well, because my primary care did an MRI because I have headaches, and he said I don't have a pituitary gland. Meanwhile, the guy's in front of you, he's talking, he looks fantastic, he has 2 kids, bigger muscles than you, he's a stockbroker making millions of dollars, and he feels great. So what do? All you do is what? Just check function. And which function again? The 2 critical to life, adrenal, thyroid. That's it. And 9 times out of 10, functionality is perfectly normal. Now there is an entity called panhypopit or panhypopituitarism. This is a little different. This is an entity or a syndrome where what? As the name implies, the pituitary is under-functioning. It's not producing as much as it should. When you see this term, by the way, the definition of this term is what? 3 axes. 3 of the anterior pituitary axes have to be defined as being deficient to say panhypopit. Otherwise, it's an isolated deficiency. When you see panhypopit as a concern in the clinical realm, as a clinical STEM question, or even in real life, the first question you have to ask yourself is why? Why? Yes, you do have to address the immediate clinical concerns, particularly if you have an adrenal crisis. But after that, why? Why is this person's pituitary not functioning well? And it could be anything compressing or damaging the pituitary, such as who? Like what? Tumors, adenomas, cysts, big balls in the tiny little cella turcica pushing on the teeny weeny little pituitary gland. Big bully, right? Pituitary doesn't like being bullied. It's very sensitive. It's like me, even though I'm from Brooklyn. It's very sensitive, right? What other entities can push and bully the pituitary gland? Meningiomas and lymphomas, malignancies. Central system malignancies, external forces, trauma. Again, we're back to radiation. The pituitary overall, I will tell you, is exquisitely sensitive to radiation therapy. This is why in the endocrine world, when we're treating pituitary tumors, radiation therapy is dropped. It's like 5th line now. It's basically the last remaining step for pituitary entities that we cannot treat medically or surgically. Don't forget the infiltrative disorders, hemochromatosis, sarcoid, histiocytosis X. They like to infiltrate and invade endocrine glands, and pituitary is one of the famous ones. Finally, what else? Those funky fungal infections, those really funky ones, blastomycosis this, histiocytosis that, histoplasmosis this, and so on and so forth. Those funky fungal infections love to chew up and eat up little endocrine glands. They're just sitting there doing their job. Who else? TB. TB is also notorious for invading endocrine glands, and particularly the pituitary. Parasites. Amoebiasis has been documented cases. So again, infiltrative disorders, bugs, funny bugs, and don't forget autoimmune disorders. Right, that's at the bottom of the list, always the case. In general, quick summary, panhypopit, something is pissing off the pituitary gland, affecting function. Tumors, strokes, infections, trauma, all causes, all pissing off, all bullying the itty weedy little pituitary gland. So, how's it going to present? The presentation will really depend on which axes are being damaged. Now again, the definition of panhypopit we said earlier was 3 or more, but again, you're concerned about the more popular axes, the popular girl in school, right? But it really does depend on the deficiency, which axis you're talking about. For example, if I had prolactin deficiency, what is it going to present as? Well, in men, it won't present as anything. Because in general, the prolactin effect in men is really if it's high, not if it's low. But in women, you may have an effect. What's that? You can't breastfeed the baby. What famous disease? Riddle me this, Batman. What famous disease leads to lack of lactation, inability to breastfeed a baby? Sheehan syndrome, which is, by the way, on your list, on your differential diagnosis of panhypopit. Postpartum hemorrhage leading to pituitary necrosis. And I'm going to tell you what I always tell all my students and residents and fellows. A doctor is only as good as his or her list. And this old psychiatry professor once told that to me when I was a third-year medical student many moons ago, and it stayed with me my entire career. A doctor is only as good as his or her list. If you don't think of it, you're not going to test for it. If you're not going to test for it, you're not going to find it. So the longer your list is, the better of a doctor you will be. What about LH and FSH deficiency? How will that present? Now this is more broad. This is more, definitive. In women, you're not going to ovulate. You have no FSH activating ovaries. Therefore, you're not going to mature eggs and you're not going to ovulate. What's going to happen to their period? It go bye-bye. Bye-bye. But period go bye-bye. You're not activating ovaries. You're not luteinizing the uterine lining. Guess what? You're not going to bleed. Therefore, amenorrhea will be how it presents. Now, I will tell you, when it comes to men, and general rule is what? Whatever affects the menstrual cycle in a woman clinically will affect sexual function in men, meaning desire, libido, and erectile function. So if you're not making LH and FSH in men, they cannot make testosterone, which means what else? Other things aren't going to work. Sorry. I know it's a little sensitive, but it's true. But it's true. I know we giggle about it, we're laughing about it, but listen, the fact of the matter is, jokes aside, it's serious. You know, when you have young middle-aged men coming to you and they have this problem and they want to, enjoy intimacy. So we giggle about it, but it's a serious problem and you need to address it, and you address it accordingly. Both will do what? They'll have decreased libido. Now, here's the interesting point. Libido is controlled, desire is controlled by testosterone in both men and women. Interesting, right? So therefore, if you have a low testosterone in women, they will also have a low libido. What else will happen? Hair. Body and facial hair, not this. This right here, this is all testosterone, baby. Too much of it. It's a Greek thing, okay? It's a Greek Brooklyn thing. But the fact is, facial hair and body hair is completely testosterone mediated. So on the scalp, what it does is the opposite what it does to the body. So if you don't have testosterone and sex hormone production, you will lose facial and body hair. Inappropriately. Now, one thing the boards also like is they like these sexy pituitary genetic disorders, hypothalamic pituitary genetic disorders, and there's a couple that they really like, and one is Kallmann syndrome. So what exactly is Kallmann syndrome? Kallmann syndrome is a genetic disorder caused by what? The KAL1 mutation, the CAL1 mutation. And what does that mutation do? It confuses gonadotropes. It's like, I'll give you an example. I punched in GPS in my car this morning, trying to go to, I had to go to New York Medical College for a meeting, and I punched in GPS, and this thing wanted to send me to the Midtown Tunnel. Oh, by the way, I live in North New York, near the Throgs Neck Bridge. Now, if you're not a New Yorker, which is really awful for you, but if you're not a New Yorker, you know exactly what I'm talking about. So the GPS in the gonadotropes is completely confused in the CAL1 mutation. Now, there are other mutations, but this is the one, this guy, that's the one that we test for the disease. Got it? What else does it cause? It causes androgen deficiency. Why? Because if you're not making adequate GnRH, you're not making LH-FSH, you're not making LH-FSH, you're not making testosterone. So therefore, you're going to have an androgen deficiency, which is why Kallmann's is exquisitely common in men and exquisitely rare in women. Again, low FSH and LH due to the gonadotropin dysfunction. What else? There are other secondary symptoms associated with the syndrome, which will be clues for you on the exam. What else? Now, like my favorite celebrity would say, do you smell what The Rock is cooking? Right? Anosmia. Because the same CAL1 mutation, and if you don't know who The Rock is, YouTube it because you have a problem, I'm just saying. The same mutation which causes the gonadotropic GPS dysfunction into the hypothalamus causes also the same GPS dysfunction for olfactory neurons. What else does it cause? Renal agenesis. I'll give you one more clue, which I see in real life and has been popping up on exams. Central defects like cleft palate. So cleft palate may be associated with a disorder. How do we treat it? We replace the testosterone, but again, I'm going to add more to this. Giving back the testosterone will treat what? Will treat the hypogonadal symptoms. The low libido, low desire, low muscle mass, voice changes, sexual function, all of that. But guys, it's the 21st century. And what's a major, major concern, which I promise you you will see on your exam. And in real life too. One thing about us here at MedQuest, I love Conrad to death, and one thing we agree with is that we like to teach to real life as well as to exams. It's important to understand. You're a real life hero, you see real people, you have to understand this. But that also crosses over to exams. Exams do cross over with what real life concerns are. And fertility is a major concern today in the 21st century for many reasons. So this could easily be converted to a fertility question, where you have the same patient who comes to you at 21, 22, who said, I just want to feel like a 22-year-old guy, but then 5 and 10 years later comes and tells you, Doc, I want to have a kid. Testosterone's not going to cut it. You have to give back the gonadotropes. You have to give back the LH or FSH. To be perfectly transparent, you could also give back GnRH. You will not and should not be asked which one's better. But understand, as far as you're concerned, for step 2, they're equivalent. GnRH or LH and FSH together, not independently. Got it? So fertility, GnRH or LH and FSH. Just gonadal symptoms, we give back testosterone. Another entity in the sexy genetic pituitary disorders is Klinefelter syndrome. Klinefelter syndrome is a little different than Kallman's in that it's not a mutation causing some type of dysfunction, it's a trisomy, 47XXY, right? It's a trisomy. It's a trisomy karyotype which leads to androgen deficiency. Particularly, this is a primary testicular failure. What does that mean? The testes are not functioning and not producing testosterone, which will lead to what? What should happen? Think this through for a minute. If the pituitary is not seeing enough test, what will it do? It should yell. And how's it going to yell? Where is the testosterone, dude? Where is it? Therefore, I'm going to yell by sending signals. FSH, LH. I need testosterone. Where is it? Where is it? Where is it? Now, in addition, due to not having testosterone on board, as far as their physical phenotype, remember something, back to basic phys. Puberty, which is a very confusing time for a lot of things, is also confusing for growth, right? We have our growth spurts in puberty. So you have the epiphyseal plate, that's what's responsible for growth. And you have a constant fight, right? On one side, you got growth hormone, ready to go with their job. On the other side, it's like UFC, MMA, Taekwondo guy versus a boxing guy, like this, right? On the other side, you got testosterone and estrogen ready to fight the growth plate. Who wins? Who wins? Well, at the beginning of puberty, growth hormone wins. The plate stays open. And you grow and you grow and you grow. But at the end of the day, guys, what I've learned in my life, started with my mommy, and ever since, estrogen always wins. Period. End of story. Estrogen always wins. And eventually the plate closes. And fellas, even in us, at the epiphyseal plate, our test is converted to estrogen. So it's always estrogen that's responsible for closing the plate, FYI. But what does that mean for these patients? If their testosterone production is very low, they're not making enough estrogen, which means what? The plate stays open longer and longer and longer. So therefore, they are tall. They're tall and they're lanky. And they're unicoid in appearance due to the lack of sex hormones. Got it? If you understand why things happen, you can answer any question they throw at you. If you just memorize questions, it's a 50-50 shot. How do we treat it? We replace it. We replace testosterone. Fertility treatment in these patients is a little more complicated. I'll admit it's a little bit above step 2, but there are assisted reproductive techniques that we could do for Klinefelters, but it is much more complicated and invasive. Now, what about isolated growth hormone deficiency? Now, this varies, and the approach varies depending on the age of the patient. In children, it will lead to short stature. It will. And therefore, typically needs to be addressed. In adults, it's a little different. In adults, you may have some symptoms, but the problem is that the symptoms it's associated with are often metabolic, hyperlipidemia, hypertension, central obesity, diabetes type 2 with insulin resistance. So they could be often misconstrued in adults. But in children, it's more clear. It's short stature. You have to understand also that GH is a very critical anti-insulin. Right? I often say this joke, if insulin's Batman, who's the Joker? Glucagon. Right? If insulin's Batman, Joker's his arch nemesis. But Batman had more great enemies than just the Joker. He had the Riddler, He had Iceman. He had all these different Mr. Frost, Mr. Frost. Excuse me, I got the name wrong. Right? So, but point being though, and GH is one of the anti-insulin. It's one of the major counter-regulatory hormones to insulin. So FYI, it's important to understand that. Adults deficient, like I mentioned earlier, it's more metabolic in nature. Insulin resistance, hypertension, hyperlipidemia, glucose intolerance, that kind of picture. Lower lean body mass, lower muscle content. So, how about diagnosis? How do we diagnose, how do we approach things involving the pituitary function, adrenals, and all this jazz that we've talked about for the past 20 minutes or so? Well, hyponatremia is one of the first things that could pop up. Hyponatremia is one of the first things that could pop up. And what you have to understand about hyponatremia, again, is the cause. And as far as when it comes to pituitary disease, I mentioned this already 10 times already, so you better get this right. What are the two axes we're concerned about? I'm scared to tell what are the two axes we're concerned about for life. They are, boom, boom, 1, 2, thyroid and cortisol, right? Boom, boom, 1, 2, thyroid and cortisol. That's what we're concerned about. Those are the axes important to life, and one of the signs may be a sodium dysfunction. What else? A very common mistake that occurs is that people, when they think of adrenal insufficiency and adrenal crisis, they think of potassium. And you're not wrong if you think that way. But you also have to understand that's primary adrenal failure, where you also lose aldosterone. And aldosterone is the main player when it comes to maintaining our blood pressure and our potassium status. The type of adrenal insufficiency you get from the central side is you do lose cortisol. It is critical, but it doesn't affect potassium nearly as much. So potassium may likely be normal. So don't forget that. Now, this is the chemical testing, right? What about radiology? What about MRI? Right? I told you MRIs are the critical imaging we use for pituitary function. What may we see when it comes to causes of pituitary dysfunction? What may we see? We may actually see the masses, the baseballs living in the pituitary that are bullying the pituitary gland. So for panhypopate, you have a clinical presentation in front of you. You have a suspicion, again, your differential, your list. What do we get as a baseline? We basically check all the major axes, thyroid, adrenal, but we also check test. And this is a very important point I will tell you when it comes to endocrine testing. Barring a couple of exceptions, TSH being one of them, isolated hormone testing is almost always useless. A random estrogen is almost always useless. A random test, useless. A random IGF-1 is useless. When you combine it with its pituitary equivalent, if I combine a cortisol with an ACTH, now I have value. If I combine a test with an FSH, now I have value. Why? Because I have insight into the actual axis, and that's what matters. But this is a good screening process. But how do you confirm the low pituitary function? Well, you have to compare functionality to actuality. So endocrine, also another reason which scares a lot of students is the special testing that we do, a lot of stimulations and suppressions. So if I give somebody a recombinant ACTH, I want to see a rise in cortisol, because that challenges the axis. If I give someone dexamethasone, I want to see suppression. So this is why I mentioned earlier, you're not really suppressing or stimulating right now, but you want to see an isolated T4 is nothing. Has very little value. But if you compare it to a TSH, now it gives you insight into the thyroid axis. If I give someone recombinant TRH, for example, right, then obviously I expect to see a rise in free T4. If it does not occur, then I may have a thyroid function, I may have a pituitary resistance problem, or I may have a dead pituitary not responding to TRH. Now we have these kind of stimulation tests for many of the axes we study. FYI, just so you know. How about recent disease? How about chronic illness? Things of this nature. What do you expect to see? You expect to see a rise in cortisol, especially after you give recombinant ACTH. Now, what about chronic disease? What if you have something, for example, diabetes for a long time? What if you have renal failure? Renal failure is a classic example of chronic disease. What will you expect to see? No rise in cortisol after ACTH. So what this boils down to is what? Primary versus secondary failure. This is what it boils down to. When you see a rise in cortisol after giving recombinant ACTH, that tells you the adrenal is fine. It's just not seeing any ACTH. If you're administering recombinant ACTH, trade name Costantropin, you guys may hear that term, that's why I'm using it, but no rise, with no rise, that tells you it's not a pituitary issue. The adrenal can't see it. Very different approach. Very different approach. What about for the growth hormone axis? How do we screen for growth hormone function? So when it comes to screening for GH deficiency, what you want to see is, again, is the pituitary responding to hypothalamic stimulation? And in the past, they used to do all these crazy tests like insulin challenges and all that stuff. Right now, we have what? We have recombinant hormones. We do. And now we give back, like I mentioned earlier, we give back recombinant ACTH, recombinant TRH. Now we can give back recombinant what? GHRH. All hypothalamic stimulants. And what do we expect to see? If we give someone GHRH, if the pituitary is normal. If the pituitary is normal, what do you expect to see if I give you GHRH? You should see what? A rise. Boom. GH to skyrocket. GH to skyrocket. That's what should happen. Arginine stimulation is a test. It's still available. I will tell you GHRH is becoming the test of choice. But if you see an arginine stimulation, it's not wrong. But just so you understand, it's also a GH stimulation test. That's it. Again, same expectation. If I give arginine, the amino acid, I should see a spike in GH. Metyrapone. What is metyrapone? If you remember back to that far-off magical place, first year of medical school biochemistry, and you did the whole adrenal pathway. If you remember, 11-hydroxylase was the enzyme at the very end of the pathway which cleaved the final products, including 11-deoxycortisol, into cortisol. What metyrapone does is he blocks that. So because he blocks that final enzymatic step, cortisol levels drop dramatically. If cortisol level drop, see, you're making me slip my tongue. Look at you. It's your fault. If cortisol levels drop dramatically, what do you expect the anterior pituitary to do? It's going to yell, right? Again, the term is lack of feedback inhibition. We've been talking about it the whole session, but that's the actual term, feedback inhibition. So if cortisol levels fall and anterior pituitary does not receive adequate feedback, it's feedback inhibition, it's going to yell. Well, how's it going to yell? It's going to yell by skyrocketing ACTH. That's how it's going to yell. And that's the underlying premise of a metyrapone challenge. If I give metyrapone, cortisol levels fall, but ACTH is like, I'm just chilling. I'm California chilling on the beach. All right, I'm just chilling. If that's the kind of response you have, that's an inappropriate response. That's an inappropriate response. And therefore, that's indicative of a pituitary insufficiency, particularly the adrenal axis. How do we treat? Well, we replace hormones, almost all of them. We do replace the cortisone axis. Again, the adrenal axis is critical to life, so we have to replace it. We have to replace the thyroid axis with levothyroxine. You don't need to give back T3. That's liothyronine. Levothyroxine, which is recombinant T4, is perfectly fine. We do replace the gonadal axis basically because of symptoms. Whether it's hypogonadal men with decreased libido and erectile dysfunction, hypogonadal women with menstrual dysfunction and premature menopause, we do that. Recombinant GH is given, particularly in children for short stature. In adults, it's arguable whether it does anything. If you see it, it's not wrong to choose it, but we will definitely see it more likely or not in children on the exam. Now, what about the posterior pituitary? The posterior pituitary is the little guy in the back everyone forgets. He's like the Tyrion Lannister of Game of Thrones. The Tyrion Lannister of hormones. Oh, he's always second fiddle to his older, bigger, handsome warrior brother, Jaime Lannister. I'm the anterior pituitary. I make ACTH. I have nice hair. I make TSH. What do? What do? You only make vasopressin. And you only make oxytocin. That's what you do. You contract and you pee. That's it. That's all you do. But like the show, like the movie and the books, Tyrion Lannister is one of the smartest guys in the story, right? Exactly. So you do not want to play, you don't want to play with vasopressin. Now, we're not too concerned with the deficiency of oxytocin, right? It does help uterine contraction during delivery, but the fact of the matter is we replace almost every woman in labor. So oxytocin deficiency is not an issue. However, like I said, if you don't take Tyrion seriously, he will have his vengeance on you. And how will he be? He will make you pee your brains out with diabetes insipidus. That's what he's going to do, right? So diabetes insipidus is either a critical loss of vasopressin due to function or a resistance at the renal level, at the collecting duct level. Because remember, in the endocrine world, If cells cannot see a hormone, they do not exist. And how do cells see hormones? Via receptors. So anything that can interfere with the vasopressin receptor, the V2 receptor in the collecting duct, will interfere with vasopressin function. That's it. Because cells only see hormones through receptors, period. So if we start with central DI, central diabetes insipidus, again, it starts with destruction, some type of lack of production. But again, always ask yourself why. You're going to have the polyuria, right? Well, you're going to have the polyuria. But you have to ask it why. Why is this person not making vasopressin? Why? Things like stroke, tumors, trauma, hypoxia, infiltrative disorders. The one that's notorious from all of them can do it. Sarcoid can do it. But the one that's notorious for infiltrating the posterior stalk, histiocytosis X. Write that down. That's a 10% question for step 2. 10% question means it's the difference between a 240 and a 250, or 250 and a 260. That's what it means. Now, for nephrogenic or renal diabetes insipidus, again, the problem is what? You can't see me, right? The vasopressin receptor cannot see vasopressin. Why can't it see it? Due to all kinds of secondary disorders, whether it's chronic pyelonephritis, amyloidosis, myeloma, sickle cell traits, electrolyte disturbances, calcium, potassium disturbances. These are all secondary reasons and causes of interference with vasopressin receptor. So, let me get out of your way for a minute. Presentation. How is it going to present? How will diabetes insipidus present? With extremely high urine volume. Again, Tyrion's revenge. He's going to make you pee your brains out. What will that high urine volume lead to? Hopefully, it will lead to thirst. You should be thirsty. If you're losing liters of urine a day, you should be thirsty. And if you're thirsty and you're losing urine, what's next? Volume depletion. You're going to dry out and turn into a raisin. That's what you're going to do. And when you turn into a raisin, what should happen to your sodium? It's going to skyrocket. Because remember, a lack of free water is equivalent to a rise in sodium. A lack of free water is equivalent to a rise in sodium. And if your sodium is rising and rising and rising, look, everyone that knows me knows I try to eat clean and stay healthy. But my one cheat food in life, my one bad food is Doritos. Don't laugh at me, okay? It's Doritos. And I'm not talking about the little 25-cent bags. I'm talking about the 3-pound bag from Costco. Put me in front of a television watching Monday Night Raw, I'm good to go. There's enough salt in one of those bags for like 2 months. So if I have diabetes insipidus and I'm eating this bag of 3-pound Doritos, and by the way, the red, if you're in my class and you want to treat me, it's the red bag, the original nachos. I don't do anything else, these new fancy types, old school red nachos, thank you very much. If I'm eating this 3-pound bag of Doritos and I have DI and I'm losing all that free water, my sodium going to like 165 will cause me to have severe neurologic symptoms. Like what? Like confusion, disorientation, lethargy, and eventually if I keep eating those Doritos, what's going to happen? I will have a seizure and go into coma. And then if that continues and I still don't learn my lesson, I will die. I'm just saying, it's just the way it is. So what's very important to understand, jokes aside, is again, it really comes to maintaining your loss of free water in DI. And if a patient does have access to free water and an intact thirst mechanism, more often than not, they will maintain their losses at least somewhat. But if you're an older patient after a stroke and you don't have access to that water, then you could be in serious trouble. So let me get back in here. Hi, welcome back. I'm back. So now a person has a great clinical story in front of you of DI. You have great high clinical suspicion. How do you test for it? First and foremost, like I mentioned earlier, you may or may not see a high serum sodium. That may be your first sign. But what's a major important correlate to your serum sodium when it comes to dealing with diabetes insipidus is not just sodium, but you're dealing with free water, right? So the major player is who? It's osmolarity. Serum osmolarity. And what will you expect to see in your serum osmolarity? If you're losing free water, your serum osmolarity should rise. It should rise. And remember, a poor man's sodium is 2 times sodium plus 10. I know there's that whole fancy equation, 2 times sodium plus glucose divided by 18, BUN divided by 2.8, blah, 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 blah. Simple, 2 times sodium plus 10. Poor man's serum osmolarity. Now, another very important point is, and very critical point for you to understand, if your hormonal axes are intact, vasopressin and aldo are intact, and your renal function is normal, whatever's happening to your serum should be happening to your urine. So if your serum is drying out Your urine should be drying out because your kidney should be holding on to as much free water as possible. And vice versa. If you have a disorder such as psychogenic polydipsia, where you can't stop drinking water and your serum becomes wet and dilute, wet for short, like we say, then your urine should be wet and dilute. Again, they should follow suit. If you have a mismatch between your urine and your serum osmolarities, there's a problem. There's a problem. In DI, your urine osmolarity, your serum osmolarity is going to be very elevated because of the lack of the free water. But where's that free water going? It's going to the urine, which means what's happening to urine osmolarity? It's going to decrease. Understand? Very important. So there's your discordance. There's a mismatch. Something's wrong. And what goes along with a decreased urine osmolarity is a urine sodium, because 99% of the time, whatever's happening to sodium is happening to osmolarity and vice versa. So, what about differences between central and nephrogenic diabetes insipidus? We have to be able to discern the difference, right? Clinically, it's very important. So, how do we do that clinically? We measure the difference between central and nephrogenic renal diabetes insipidus based on the response to who? Based on the response to who? Tyrion Lannister. No, vasopressin. Vasopressin. That's what you want to see. Will the kidney respond or not respond? So if it's central diabetes insipidus, vasopressin is not being created for whatever reason, trauma, tumors, radiation, whatever. If I give back vasopressin to that patient and the renal mechanisms are intact, what should happen to my urine volume? Urine volume will decrease. Because why? Because that vasopressin now is forcing all that free water, it's like right out of the urine, back into the serum. So urine volume will decrease and urine osmolarity, if free water is leaving, what's going to happen to urine osmolarity? It's going to increase. Got it? In nephrogenic diabetes insipidus, what's going to happen? You can't see me. Nothing. Because that vasopressin receptor is resistant to vasopressin. So you will have no reaction. Urine osmolarity will stay wet, it will stay low, serum osmolarity will stay high, and that will be that. Central diabetes insipidus, how do we treat it? Well, we give back the vasopressin. We give it back as vasopressin or desmopressin, which is a long-acting analog. Same, as far as you're concerned, same difference. Nephrogenic diabetes insipidus, how do we manage that? Now that's a little trickier. First and foremost, you treat the secondary causes, such as the electrolyte disturbances. If you do have calcium problems, potassium, magnesium, phosphate, any one of them, if you have an electrolyte disturbance, you have to correct it. Presuming all those are corrected, what else may we use to treat nephrogenic diabetes insipidus if it's not going to respond to vasopressin? Well, it took me 3 years of residency, 1 year of chief residency, and 2 years of fellowship, and Conrad Fisher in my life for 12 years to finally understand how the mechanism of thiazide diuretics and amiloride work in nephrogenic diabetes insipidus. What they do is they actually trick the proximal tubule into reabsorbing more free water. That's what they do. In short, that's what it is. That's the mechanism. So therefore, the free water you lose in the collecting tubule duct side, you reabsorb most of it on the proximal tubule side. That's how that works. Non-steroidals work by constricting the afferent arteriole, and by doing so, you allow increased filtration time. So that's why we use that to treat nephrogenic diabetes insipidus. Now, next up in the pituitary realm, acromegaly, from the Greek word akros, which means extremity, and megalo, which means big. Big Greek extremities. And where does this come from? It comes from too much growth hormone. Not souvlaki, not olives, not wine. Big Greek extremities come from too much growth hormone, right? But despite popular belief, it's not just soft tissue overgrowth. It causes other problems as well. Acromegaly is not the Jolly Green Giant. Anyone remember what famous wrestler died of acromegaly? Very famous wrestler, Andre the Giant, 44 years old, right? 44 years old, he died of acromegaly. So acromegaly is not the Jolly Green Giant. It actually carries a very high mortality associated with it, untreated. The only difference is the reason why we don't feel it clinically is because it's not very common. I mean, I'm doing the endocrine thing now for about 10 years. I've seen maybe a handful of cases of acromegaly. It's not very common. It is the second most common productive pituitary tumor though. After prolactin, it is number 2. But it's still not very common, but the mortality rate's very high, so we can't ignore it. So it's almost always caused by what? A pituitary adenoma, a benign tumor overproducing GH. It can also be associated with men, because remember, MEN1 in particular is terrible P's, pituitary, parathyroid hyperplasia, and the endocrine pancreas, not carcinoma, but the endocrine pancreas. So more commonly than not, it's a pituitary non-functioning adenoma, but it could be acromegalic as well. Very well could be. So MEN1 again, parathyroid, calcium, and pancreatic disorders begin the endocrine pancreas. The endocrine pancreas, not carcinoma. Gastrinomas, insulinomas, VIPomas, et cetera, et cetera, et cetera. Rarely, you could have some small cell lung cancers that could produce GH or GHRH, but those are few and very rare and far between. So how does acromegaly present? How does big Greek extremities present? Well, the hat, ring, and shoes, I gotta tell you guys a secret. USMLE knows that I know, that you know, that they know, that I know, that you know, big rings being hats, gloves that don't fit, shoes don't fit, they all know that. They know that you know that. So where's the money in acromegaly? The money in acromegaly is in other common presentations. And I gotta tell you, in the new exams, in the USMLE level, even at the ABIM level, they're using some of these other presentations to try to catch you. But you know what? Because you're chilling with me, now you'll know what these other presentations are. Carpal tunnel is one of the biggest ones. Why? Because of bone overgrowth. Remember, after the epiphyseal plates close, bone can't grow tall no more, so it grows wide. It can't grow tall, so it grows wide, leading to nerve obstructions. Carpal tunnel is famous, but it could be other nerve obstructions as well. Ulnar tunnel in your feet, nerve obstructions in your feet. What other kind of bony growths? Bossing of the frontal lobe. So bone disorders are not uncommon. What else? Obstructive sleep apnea. Why? Because of the weight gain, because of the soft tissue swelling and growth in the throat. What else? Back to my favorite celebrity. What does The Rock smell? Right? That's right. Sweat gland hypertrophy. Right? You smell worse than a teenage boy. Sometimes you do. It's true. It's true. Body odor. Again, facial changes, teeth widening. Also, we naturally have an underbite. An overbite. That's natural for our jaw. Acromegalic patients sometimes can have an underbite. We naturally have an overbite, but acromegalics can develop an underbite. So that's also atypical for them. Big tongues, tongue overgrowth. This is a big one. Colon polyps and stink tags. This one right there at the bottom, that one right there. Why? Because they're going to try to trick you with colonoscopy screening questions, tricksy little hobbitses. They're going to try to trick you, saying, do acromegalic patients require a different colon cancer screening schedule? And the answer is, no, sir. GH does not cause cancer. GH feeds cancer cells that may already be growing. Very important difference. So colon cancer screening schedules do not change for acromegalics. Write that down. Write that down. Arthritic type pains, joint pains. But what kills them? What kills acromegalics? What killed Andre the Giant? Cardiomegaly and accelerated coronary syndromes, left ventricular hypertrophy, all kinds of cardiomyopathies. That's what actually kills and gives it such a high mortality rate. How about erectile dysfunction? That comes from what? So 8% of acromegalic patients, or approximately 8%, co-secrete prolactin. They do, it's part of the same mutation. Now, why is that important for you? Because not only for the symptomatic portion of it, but the treatment portion of it later on, which we'll discuss. Also, if you remember what I mentioned earlier about growth hormone is one of the enemies of who, Batman, of insulin? So if you have an excessive GH, what else may happen? Your sugar is going to rise. So hyperglycemia and a new onset resistant diabetes may be one of the presenting signs in a young person of acromegaly. New onset resistant diabetes. And piggybacking on that, also write down new onset resistant hypertension. That can happen too. What about exogenous use of growth hormone? Unfortunately, a lot of professional athletes and bodybuilders use it for competitive advantage. The fact of the matter is, it will give you the same symptoms. It will give you the same symptoms as acromegaly. The only difference is, once you stop using it, they should resolve. The symptoms should resolve. Now, you have a good clinical presentation of acromegaly. It's in front of you in your office, in the clinic, wherever you are. How do you test for it? So, the gold standard test for it is actually a glucose tolerance test. But before we get there, the best initial test is IGF-1, insulin-like growth factor 1. Why? Because growth hormone is up and down. Up and down. Up and down. It's like a yo-yo. Why is it up and down? Because so many factors affect GH release from the pituitary. Sleep, glucose intake, exercise levels, sleep cycles. All these things affect GH release. IGF-1 though is more steady. It's like this. IGF-1 is like that, more steady. Right? IGF-1 is produced by the liver with the stimulation of GH. So that's what we use as a screen. And I will tell you in the very, very latest updated guidelines, because we are so up to date here at MedQuest, if you have a high clinical index of suspicion, hats don't fit, rings don't fit, nuance, resistant diabetes, carpal tunnel, sleep apnea, soft tissue growths, all of those clinical findings, and your IGF-1 levels through the roof, super high, undetectable, you're actually done. You've made your clinical diagnosis. You could say you have acromegaly. But if you still need a gold standard confirmation, it is a glucose suppression test. Why? Because GH does not like sugar. Like I mentioned earlier with the whole insulin Batman joke. It does not like sugar. So if I give somebody 75 or 100 grams of glucose and measure their GH levels an hour or two later, if they're not acromegalics, GH will be 0. It should be 0 and it will be 0. If I give someone 100 grams of glucose and measure the GH 2 hours later and it's still high, that's inappropriate. You have confirmed GH excess. You have confirmed GH excess. Clear? Once you have chemically confirmed GH excess, now what do? You go fishing. With what? Your MRI. Now you go fishing. So this is a very important point in endocrine, both on exams and in real life. Rule number 1, don't go fishing. And what do I mean by fishing? Radiologic studies. I promise you, remember me, the bald Greek guy from Brooklyn, remember me. In the words of Achilles going to Troy, remember me, right? Remember me. You're going to be on the exam, on exam day, in front of you, and you're going to be reading a case, and it's going to look, and it's going to smell, and it's going to stink of acromegaly. And you're going to be drooling and saying, I got this, I got the diagnosis, I know what they're going for. And they're going to ask you, what do you want to do next? What's the next best step in the management of this patient? And you're going to see pituitary MRI there. And you're going to want to pick it so bad, like you're going to be cramping, your fingers are going to be cramping to push on the mouse, but you're not. Why? Because you're going to remember me. And you're going to remember what I'm telling you. Don't go fishing. When it comes to endocrine disorders, overall, this rule applies to almost all of them. Almost all of them. You need chemical confirmation first, before you look for it. Once you have chemical confirmation, boom, boom, IGF-1, glucose tolerance suppression, boom, 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 now you go fishing. Now you want to find the pituitary adenoma producing it. Understand? Very important point. Always check prolactin levels along with IGF-1 and GH levels when you're assessing acromegaly, again, because that 8% co-secretion rate, it's high, and it does affect your treatment plan later on. So how do we treat acromegaly? Well, the treatment of choice today, as of right now, it's still surgery. It's a surgical disease. You want to go out and remove the tumor. And what the problem is, because acromegaly is a slow process and the disease is very slow, very often patients don't feel or see the symptoms until it's a long-standing disease. And surgical resection is hard to do 100% resection. If the neurosurgeon can grab the entire tumor, that's fantastic. That's a treatment of choice. It's curative. But rather often than not, it's already invaded the cavernous sinus. And because of that, you need surgery plus medical management. And what medical management can we use? Can we use cabergoline, which is the dopamine agonist. It's the only dopamine agonist approved for acromegaly. Don't fall for bromocriptine, it's wrong. If you see it, it's wrong. But cabergoline, the primary indication for cabergoline is an add-on to who? Somatostatin analogs. These are your drugs of choice, these guys. Octreotide, lanreotide, only 2. And they're not going to ask you which one's better because they're not, they're equivalent. So these are the drugs of choice. They're somatostatin analogs. And then you can add on the dopamine analog cabergoline if you're in that 8% co-secretion rate. That's why I told you it's important to understand the prolactin role of acromegaly. Who's Pegvisomant? Pegvisomant's the newest guy in the block. And to be honest, it's not that new now. It's about 9 or 10 years old. And he is a GH receptor blocker. He blocks the GH receptor at the liver, which means what? You're not making IGF-1. That's what it means. You're not making IGF-1. Pegvisomant is approved. It's an add-on for recurrent or resistant acromegaly post-surgery that you've already had a somatostatin analog on board. and a dopamine cabergoline on board, and you still have residual disease. You add on pegvisomant. It's very good. It's very good at what it does. Radiation therapy is, I told you, that's your last stop, folks. You have you've operated, you have every medication on board, and GH and IGF levels are still high. Then we just blast the pituitary, we blast it, whatever's left. You do have complication rates. Radiation therapy has a panhypopit you have to worry about, and that can happen up to 20 years down the road. You can have secondary cranial tumors. They have a twofold increased risk of stroke. After radiation therapy, the cerebral arteries do not like radiation therapy. So RT is not benign. We do have focal RT, which is better, but nonetheless, it's our last line of defense. So if GH is an anti-insulin, why does it make insulin-like growth factor? Why do we park in a driveway and drive on a parkway? Well, because the fact of the matter is they have similar effects. IGF-1 works on the protein side, but people forget insulin's a growth factor too, right? It causes the production and growth of proteins and incorporation of amino acids into protein chains, which is what IGF-1 does. So chemically, there's a resemblance there, but that's it. Now, I mentioned earlier, the number one most common productive pituitary adenoma is prolactin. It's a hyperprolactinemia, it's a prolactinoma. However, understand that hyperprolactinemia can have secondary causes. They can have secondary causes. Now, acromegaly is the one that we discussed earlier, but what other secondary causes can elevate what's the most common cause of hyperprolactinemia in the United States? I'll do you one better. What's the most common cause? Which everyone misses, by the way. Everyone misses. It is pregnancy. That's right. Yeah. Ooh. Oh, damn. Yeah. It's pregnancy. Pregnancy is a hyperprolactinemic state, folks. Everyone forgets. Other secondary causes include hypothyroidism due to the TRH spike. The TRH spike stimulates prolactin production. Don't forget pregnancy and renal clearance. If you have renal insufficiency, lack of renal clearance will raise your prolactin. Now, there's something called, the phenomenon called the stalk effect, right? The stalk effect. What's the stalk effect? The stalk effect is, you have to understand prolactin is unique. It's unique amongst the anterior pituitary hormones in that it's the only one that does not have a hypothalamic stimulant. It's the only one placed under what's called tonic inhibition. But why, Chris? Why is prolactin under tonic inhibition? Well, because prolactin is responsible for milk formation and production. And do you have any idea what it costs a mom to make milk? Any idea? The average caloric value per one breastfeeding session is 300 to 500 calories. Creating milk costs mom a lot of resources, nutritional resources, calories, proteins, fats, minerals, vitamins, all these things. So nature says, you are not making milk unless you're feeding a baby. Why? Because I have to be budget neutral. I have to be budget neutral. So nature says, you know what? If I'm gonna burn resources, nutritional resources, it better be on the continuation of your species. How about that? And what's the signal that tells the pituitary that there's going to be a continuation of the species? Estrogen. That's why all estrogens raise prolactin. Pregnancy, of course, being one of them. Birth control pills, etc. But the tonic inhibitor is who? Dopamine. That's the guy that goes and tells the prolactin, not yet. We're not pregnant yet. No, Pookie. I'm going to tell you when you make milk. That's it. Budget neutral. In stalk effect, what happens? You have an obstruction in the circulation between the hypothalamus and the pituitary. So what's the old saying? Was it when the cat's away, what happens? The mouse plays? In this case, the cat's away. Dopamine can't reach the anterior pituitary. Therefore, prolactin's like, woo, I'm gonna go crazy. We're pregnant. If dopamine's not around, we're pregnant. And that's what prolactin rises. That's called the stalk effect. Medications. A lot of medications can affect prolactin levels, particularly medications that do what? That play with dopamine, such as the antipsychotic, anti-schizophrenic medications, methyldopa. Metoclopramide is also on the list, used for gastric disturbances and so on and so forth, can raise prolactin levels. Opiates and tricyclic antidepressants can also raise prolactin levels. There is a famous question step 2 likes, which is the only calcium channel blocker that raises prolactin. And that is who? Verapamil. It's one of those things, memorize it. They like asking the question. So, now I'm giving you a case. What if you have a woman who presents with what? What's it going to present with when you have high prolactin? Galactorrhea, milk production. What else will prolactin do though? Think about this now. I alluded to this earlier. If nature wants to be budget neutral when it comes to nutritional resources and control milk production, if nature thinks I have to control milk production for nutritional resource, what about the back end of that? What about, okay, you have a baby, you're breastfeeding and feeding one. What does that mean? Remember, 20,000 years, we're not talking about 2019 now, we're talking about 20,000 years ago when resources were scant, right? If you're breastfeeding a baby, can you afford to get pregnant by your caveman husband again? Probably not, because you ate a bushel of berries. You didn't know when you were eating again, right? You were eating. That's the way it went. So how can nature protect mom from her caveman husband? Shutting her period off. No period, no pregnancy. No ticky, no laundry, right? No period, no pregnancy. So prolactin shuts off the gonadal axis for exactly that reason. That's why it's often called nature's birth control pill. But when you shut off the gonadal axis, what you may also cause, unfortunately, in people that want to get pregnant is infertility. Without the gonadal axis, a woman can't get pregnant, right? It's going to shut off FSH and LH, and therefore you won't have ovulation. How about men? The presentation of women is fairly well known. What about where people often get stuck is what's it going to present like in men? And if you remember what I said earlier, the same disease states that affect a woman's menstrual cycle will do what in men? What did I say? It will affect their what? Their sexual function, erectile dysfunction, decreased libido, desire. Long term, it may cause gynecomastia and galactorrhea, but I will tell you, it's rare. Don't fall for that trap. That's not the presenting symptom in men. The presenting symptom in men is decreased desire and erectile dysfunction. And, like I mentioned earlier, don't go fishing. Chemical confirmation of the prolactin excess first. Confirm there's no secondary causes. No pregnancy, no thyroid disease, normal renal function. Then you go fishing. Then you do your pituitary MRI. So once you do that, and you found your prolactin levels are elevated, you're going to check your thyroid levels, you can do your pregnancy test, liver, renal clearance testing, and then what are you going to do? Then you're going to do your MRI. Then you're going to do your MRI, and then you're going to find it. And you're going to find pretty much an adenoma. But again, I can't harp on this enough, folks. Please, please, please make sure she is not pregnant. Boards love asking this question, and they ask it every year on every board level. We're talking from step 1, 2, all the way through subspecialty boards. They love making sure that you know to make sure a woman's not pregnant, and they can ask it in many different ways. So please, if there's any kind of menstrual disturbance in a woman of reproductive age, which for all intents and purposes, as far as you're concerned, is 15 to 50, 13 to 50. And you see what's the next step, and you see a beta HCG there, you pick that. I'm telling you, pick it. Once you've confirmed a prolactin excess and a prolactinoma, how do we treat it? Dopamine agonists. Again, we want to use nature's natural inhibitor. And cabergoline is the drug of choice. It's easier tolerated, it's cheaper. Bromocriptine is number 2, and those are basically your 2 options. Now, transfemoral surgery is an option, but I will tell you, it's almost never done. The dopamine agonists are very, very good at what they do. They're excellent at shrinking or making even if it's a microadenoma, more times than not, it will disappear. But they're very good at shrinking, and they're very, very good at what they do. Side note, write this down, 10% question. If they give you a case of a prolactinoma with visual field impairment, which can occur, as the tumor enlarges, it can affect the optic chiasm. Remember the optic chiasm on top? It's on top of the pituitary. And they try to bully you, saying, what do you want to do next? They try to scare you, vision impairment. And surgery is an option. And cabergoline's right below it. You pick cabergoline. You pick cabergoline, folks. You will see a resolution of the visual symptoms within 48 to 72 hours. That's right. That's right. Trust me. Radiation is rarely, if ever, needed. Rarely, if ever needed. Very rarely, if ever needed. Now, what about gynecomastia? Now, the definition of gynecomastia is increased breast tissue in men. And don't forget, now, this is a natural occurrence in men. Fellas, we have some breast tissue, but it's just a minuscule amount. And it's not uncommon for boys and men going through puberty and young adulthood to have breast tissue remnants. It's not uncommon. The question is, what do you do about it? You do have to look for secondary causes. I mean, Klinefelters can do it. Prolactinomas and hyperprolactinemic states can do it. Drugs can do it. Liver and renal failure can do it too due to lack of clearance. Don't forget, a testicular sonogram is always a good answer. Why? Because of Sertoli cells that are estrogen producing, a Sertoli tumor. So an estrogen productive state can cause gynecomastia. So once you exclude the previous disorders, then what's important, you need to do mammography. Whether it's, you could do x-ray mammography, a sonogram is not wrong, you should not be asked which one's better at your level, but it could be a breast sonogram or it could be an x-ray mammogram. How do we treat it? You replace the testosterone if it's low, but surgery is a serious consideration, particularly if the tissue remnant lasts after the age of 21, because they do have a slightly higher risk of conversion to male breast cancer. And male breast cancer is a much bigger concern than female because we have much less fat tissue protecting us from invasion. So more often than not, surgical consultation may be necessary, all right? And folks, that brings us to the end of the pituitary section. Hope you all had fun. I did. I will be seeing you shortly for thyroid.